Okay, it's 11:01. So, good morning, folks. My name is Colin Irwin. I'm a member volunteer in the Hydro Pensioners Association of Ontario, Toronto's chapter, and this is our third Zoom meeting. Today we have Dr. Sharon Cohen of the Toronto Memory Clinic, who's volunteered to talk to us about the latest research
Almost started.
I beg your pardon? Latest research in Alzheimer's and memory. Dr. Cohen, if you'd like to go ahead.
Yes, sure. Thank you. Thanks very much. I am going to share my screen. Just bear with me for 1 minute and you should see slides in a moment.
And folks, just as what I'm going to do is I'm just going to mute everybody just to avoid any background noises while Dr. Cohen's making a presentation. You can choose to unmute at the end when you we have a question and answer session, and throughout the meeting, you're welcome to put questions or comments in the chat or raise your hand.
Okay.
Sorry.
It looks good. Oh, Dr. Cohen, you're muted.
Oh, sorry, Dr. Cohen, I think I muted you too. If you don't mind unmuting yourself, please.
Okay, can you hear me now?
Perfect. Yeah. Yes. Thank you so much.
No worries, no worries. Okay, thank you. It's a pleasure to be with you this morning. I hope everybody's well. I am a neurologist. I specialize in Alzheimer's disease. I have done so for the past 30 years. So I've examined and treated and guided thousands of patients with this very challenging disease. And I also have family members who have been affected. So I'm very connected with what's going on in the field, and I hope to share some new insights with you. So let me just try and advance there we go. So this is what I'm going to try and cover in the next 45 minutes, and then we'll have a question and answer session. I want to bring us up to speed on what is Alzheimer's disease, because there's a lot of confusion about what this is. I also want to provide an update on recent advances in diagnosis and in treatment. We are gradually making important progress, and I think you'll be glad to hear about it. And I also finally wanted to provide a call to action for those who want to get involved and do something more. Perhaps you're worried about your memory or somebody else's memory who's close to you, and there are things that can be done. So let's begin. What is Alzheimer's disease? This is a slowly progressive disease of the brain that gradually causes impairment in memory and thinking. And when I say thinking, I mean reasoning, judgment, problem solving, navigation, so wayfinding, calculation, word use, language. So not just memory, although we think of Alzheimer's disease as primarily a disease of memory, it encompasses much more than that. As cognition declines, there is a gradual loss of independence in day-to-day function from one's previous baseline. And this starts out with loss of high-level activities such as driving, banking, working, traveling independently. But as the disease progresses, even basic activities such as dressing oneself or toileting oneself, showering, these abilities are lost as well. So you can see this is a very serious disease. Altered behavior is another feature of Alzheimer's disease, and this can take the form of depression, anxiety, wandering, delusions, thinking your home is not your home, or thinking that people are stealing from you. So again, this adds to the complexity of the symptoms experienced by the patient and for the family. This is a highly feared disease, and to date it has no cure, although I am hopeful in the future we will have a cure, but it will continue to take a lot of hard work to get there. This is an expensive disease, not just for patients and families, but for our healthcare system. And the expense, people often don't realize, is more than heart disease and cancer combined for our healthcare systems. Most of the cost is later in the disease, related to long-term care, and emergency room visits and hospital stays. It is the commonest cause of dementia. So Alzheimer's disease causes dementia. It's not the only cause of dementia. If you have a stroke or a brain tumor or a head injury, that can also cause dementia, but Alzheimer's is the commonest cause. But it is more than just a dementia. And this is really important. Alzheimer's disease starts silently in the brain with changes going on in brain proteins and function. And gradually, enough brain cells are injured or lost that we develop symptoms. But the symptoms do not immediately render one without ability to function. They start as mild memory lapses, difficulty coming up with words, and things that get conflated with normal aging. We all forget things at times, even if we have an excellent memory. We all have that tip of the tongue phenomenon, can't think of a word when we're speaking. And we're used to that as being normal. But when that increases, that may be an early sign of Alzheimer's. So the dementia stage of Alzheimer's disease is actually the last stage. It's an important stage because that's when people are most vulnerable, need the most care. That's where the costs escalate. But it is important to recognize that Alzheimer's disease has a pre-dementia phase as well. So let's talk about diagnosis. The disease was first described in 1906 by a German neurologist and psychiatrist, Dr. Alzheimer, and it was later named Alzheimer's disease after him. And the first patient reported was his patient, Auguste Dieter, a German housewife. She was 51 when she developed memory symptoms, and her symptoms progressed. She became very disorganized in her behavior, and she died later in her 50s, and Dr. Alzheimer examined her brain under the microscope. And I'll show you the characteristic signs that he found. But if we fast forward to 2024, this is anything but the rare disease that was thought of in the day of Dr. Alzheimer. This is a very common disease. And here are some of the characters who in later life, the celebrities or politicians that you may recognize, who developed Alzheimer's disease. By 2030, this is around the corner, there'll be 75 million people worldwide with the disease. And by 2050, it's estimated there will be 150 million. So unchecked, this disease is on the rise. The World Health Organization has deemed Alzheimer's to be an urgent healthcare priority. The numbers are staggering. This is a very severe disease. When we talk about severe morbidity, we mean this disease is not common in the way that migraine's common. That's a common disease, but people don't die of migraines and people don't lose their jobs because of migraines. This is, and people don't require personal support workers because of migraines. So severe morbidity with Alzheimer's and enormous cost of care. And you would think with a common disease, we would be good at diagnosing it. But the reality is that only about 50% of people are ever diagnosed. So just the tip of the iceberg. And those who do get a diagnosis receive that only after several years of symptoms. So they are told things like, don't worry about it. This is normal aging, or, it's just a bit of forgetfulness. It's not important. Come back if it gets worse, rather than our healthcare system trying to catch this early and recognizing this may be the beginning of something quite serious. So, why are we so poor at diagnosing this? Well, there are a number of factors that I've alluded to, and other factors are that the person with the condition, him or herself, may not actually recognize or report symptoms. The part of the brain that allows you to know how you're doing may not be working early in Alzheimer's disease. So you have people who have very clear memory loss, and yet they feel there's nothing wrong with them, and they're not denying their situation in a psychiatric sense. They really do not appreciate that there's a problem. So that's one reason people don't come forward. Other people are very aware that something's changing with their memory, but they're fearful of stigma, and they're fearful of loss of independence and of being a burden. They don't want their doctor to say, you've got Alzheimer's, there's nothing I can do for you. That's just a terrible situation. So, and they don't want to go to the doctor and then go home having lost their driver's license because they reported memory loss to their doctor. So again, stigma is real. We need to get rid of that. Physicians themselves are part of the problem because many lack the skill or the interest to diagnose Alzheimer's. They don't feel they have the ability, they don't have the time or resources, and they find it challenging to know where does normal aging end and a disease like Alzheimer's begin. Our cognitive tests were developed for people with the dementia stage of Alzheimer's. So diagnosing early, our tests may not be very sensitive. So that's been another problem historically. And here you see that Alzheimer's disease is a long disease. It's about a 30-year disease. That may surprise some of you. And there is a stage that we call the preclinical or pre-symptomatic stage, which is actually the longest stage of the disease, where brain cells are being injured by changes in the brain, but this is silent. People may not have any symptoms at all for 15 to 20 years. And then finally, we get this mild cognitive impairment stage where people are still functioning independently, traveling, working, shopping, driving, banking. However, there is an objective memory impairment that we see, and the patient, him or herself, will know something's not quite right, but they're able to compensate. They're able to, take notes or use reminders or whatever it is so that they can still function. But gradually we get to the dementia stage, and that's usually divided into mild, moderate, and severe dementia. This is what Dr. Alwa Alzheimer saw in the first patient described with Alzheimer's disease. He looked under a light microscope and he saw amyloid and tau. Amyloid's that brownish, smudgy protein, and tau, those little black dashes. He didn't call them amyloid and tau. He called them plaques and tangles. He didn't know that they were made up of amyloid or tau. It wasn't until much later that we were sophisticated enough to understand the biology better. But nevertheless, these are the hallmark proteins of Alzheimer's disease. This is not normal aging. This is a specific disease, Alzheimer's disease. The brain shrinks in Alzheimer's disease, and it shrinks by a lot because millions of neurons die and drop out. And so you get a brain that has lost at least a third of its brain cells. If you do a PET scan using an amyloid tracer, we can now see in the living person and early in the disease, we don't have to wait till the dementia stage, we can see early in the disease the amyloid plaque buildup. And so you see an individual on the PET scan table, and on your right, you see the red lighting up, that's amyloid. And this person could be at the mild cognitive impairment stage. This person could still be working. This person could be even earlier at the pre-symptomatic stage, and yet amyloid has built up substantially, predicting that this person will go on eventually to develop the dementia of Alzheimer's disease. Another way that we now can be very clear about diagnosis is with a spinal tap. And although to some that sounds very invasive, we do this as an outpatient procedure in our clinic almost every day. People tolerate it very well. We freeze a small area of the skin in the back. We use a skinny needle. We collect some fluid around the spinal cord in the spinal space, and we send it to a special lab. And the lab will tell us whether there is amyloid accumulation, and it will also tell us about the other protein, tau. So a very good way to confirm or rule out a diagnosis of Alzheimer's disease. Blood tests. You may have heard about blood tests coming, and in the United States, they've already started to be used. Imagine being able to diagnose or rule out Alzheimer's disease by a blood test. Well, over the past year, we have blood tests that are 90% accurate now in terms of predicting whether a PET scan would show amyloid plaque. That's a very high level of accuracy, and we expect these blood tests to have regulatory approval in the next 1 to 2 years. Another modality for early diagnosis is a retinal scan. And some of you may have heard of eye scans, and this is a topic that was of interest even 10 years ago. Can you do an eye scan to detect Alzheimer's? And then it didn't work very well, and then other technologies were developed. ReadySpec is a company that has a hyperspectral camera, and it mounts onto the usual equipment that an optometrist or ophthalmologist would have in their office. And by taking a picture with this hyperspectral camera, you can see the back of the eye, which is really the front of the brain. The retina shares the same tissue as the brain, and we can see the signature of amyloid. So this is non-invasive. You don't need a spinal tap. You don't need an expensive PET scan. Validation studies are underway and look very good. So we are hoping that ophthalmologists and optometrists in the not too distant future will be involved in screening for Alzheimer's disease. So when you go for your annual eye exam and are checked for macular degeneration and all kinds of other eye diseases, another component of the ophthalmologic screening would be to rule out Alzheimer's. What about genetic testing? Let me take a few minutes to talk about this. People often ask, is Alzheimer's disease hereditary? There are rare gene mutations that can be detected in a blood sample, and these cause about 1% of all the cases of Alzheimer's disease. Now, even though these gene mutations are a rare cause of Alzheimer's disease, there are about 300 of these mutations, and we can test for all of them with a blood test. And we do this in our clinic when there's a family history of more than one close family member. If mom and a maternal aunt or mom and maternal grandmother had Alzheimer's disease, then that would be the scenario where we would offer testing for rare gene mutations. There are also risk genes that are different from these gene mutations. If you have a gene mutation that causes Alzheimer's disease, that is what we call a deterministic gene mutation. If you have it, you will develop Alzheimer's. With risk genes, this doesn't guarantee one develops Alzheimer's, but it helps stratify who's at higher risk. You may have heard of the ApoE4 gene. It is one of 3 ApoE gene types. And again, we can detect this in the blood and also from a cheek swab. So individuals who have risk genes or genes that cause Alzheimer's disease often take care of themselves better. They don't end up jumping off subway platforms and bridges as was worried, as the community had worried before. Scientists have actually studied the response to genetic testing in Alzheimer's disease. People are often eager to know what their level of risk is and then do something about it. And there are prevention and treatment studies for individuals who have these kinds of genes. Here you see Kathy Barrick, who's the CEO of the Alzheimer's Society of Ontario. She came to us and said, I want to lead by example. I want to have the ApoE testing. And we did it using a very ingenious device. It's called the Genomatics Cube. This is the smallest DNA analyzer in the world, and it was developed by Spartan Bioscience in Ottawa, a Canadian company, and it's now used in many countries. So it's a 4x4-inch cube. We collect a cheek swab, we put it in a cassette, put it in the cube, and within an hour, we get a readout of whether one has 1 or 2 copies of ApoE4 or no copies. So if you have 1 copy of ApoE4, your risk of Alzheimer's disease is 3-fold greater than that of the general population. If you have 2 copies of ApoE4, you're at 10-fold higher risk of Alzheimer's. So that's a very high risk, and those individuals really should consider joining a prevention study or a treatment study, depending on whether or not they have cognitive symptoms. So it's amazing that we've moved so far forward with PET scans, spinal taps, blood tests to come, retinal scans to come, and to be able to diagnose the disease accurately and early is so important, but even more appealing if we have treatment. So you want to say, okay, you have Alzheimer's, here's what we're going to do about it. So how are we doing in terms of new treatments? So the current treatments we've had for about 30 years, and they offer mild or modest benefit to symptoms, and that's important, but they do not prevent or slow down the underlying disease. So that's a distinguishing factor. So when you treat symptoms, you can improve memory for a while, but the underlying amyloid and tau and inflammation and other biologic factors in the brain continue. So individuals will get a bump up initially and then a slow decline. And importantly, none of these medications that came about in the late 1990s, early 2000s are approved for the mild cognitive impairment stage of Alzheimer's. So individuals have to wait until they get worse before they're treated, which doesn't make sense in modern medicine when we're trying to catch things early and treat early for better outcomes. We don't like to tell people, oh, you've got the disease, but this medicine doesn't work for you until you're more affected. So these are some of the problems with the current medications. Very, very importantly, the drug development pipeline for Alzheimer's disease has grown enormously over the past 10 years. And this is what it looks like this year. There are 127 drugs under development. It's a very complicated, busy slide. Don't worry about it. I'll orient you to it. The outer circle represents drugs in phase 1, so just coming in to clinical testing. In the middle circle, you have drugs that have made it to phase 2. And then in the inner circle, these are phase 3 drugs. If successful, they will come to the market. That's how drug development works. And the pie is divided into wedges here. And we see that the green and the purple represent drugs under development to slow Alzheimer's disease. So what we call disease modifying or disease slowing medications. Some of them are biologics. That means they are antibodies or large molecules given by intravenous or injection. And then some are small molecules that one can take by mouth. A smaller portion, but still important portion, the orange and the blue, are for treating symptoms. So there's a very clear recognition that we need to slow the disease, we need to catch it early, we need to treat symptoms, but we need to slow it down so that people don't progress to later, more disabling stages. And importantly, not only are there drugs under development in all phases, 1 through 3, but for all stages of the Alzheimer's continuum. The pre-symptomatic stage, so these are called prevention studies, where people don't have symptoms or are cognitively normal, and we're giving them, for example, an antibody to clear amyloid, because amyloid has accumulated very early, even before people develop symptoms. We have many studies also at the mild cognitive impairment or MCI stage, and studies at the dementia stage. When I started in practice, all studies were at the dementia stage. We were completely ignoring the pre-dementia mild cognitive impairment stage. We had no prevention studies. So again, much more hopeful time now. A new era of treatment began in 2021 and is continuing to grow. And we hope to see the manifestations of that in Canada. The FDA in June 2021 gave conditional approval to a controversial drug, Aduhelm or aducanumab. But importantly, this was the first biologic drug to slow Alzheimer's disease. In July 2023, the FDA gave full approval, so not conditional approval, but full approval to a second biologic called lecanemab or Leqembi. And just this last July, a few months ago, the FDA gave full approval to a third biologic, donanemab, or Kisunla is the brand name. So in the US, there have been 3 approvals. The last 2 are the most important. These are the fully approved biologics to slow disease. These are all antibodies. They clear amyloid robustly from the brain. They're given by intravenous infusion, and they are indicated for early stages of Alzheimer's, the mild cognitive impairment and the mild dementia stage, with the goal of slowing progression, keeping people in mild earlier stages where they're still functioning in their own homes. Here just to give you a visual of what these antibodies can do. You see on the left a head full of amyloid, that red on a PET scan. And this was from Nature magazine with aducanumab. You see that after several treatments, there is no amyloid on the PET scan. You've completely cleared that from the brain. It's remarkable. So this was the first time that we saw the power of these anti-amyloid antibodies. And we've subsequently seen this with lecanemab and donanemab as well. So lecanemab and donanemab, as I said, slow decline in cognition, they slow decline in daily function, they reduce the risk of transitioning to the next more disabling stage of Alzheimer's, and they also improve the markers of biology. They clear amyloid, they reduce tau, they reduce brain cell loss, and they reduce inflammation. So even though the antibodies target amyloid, they have all these downstream beneficial effects on the brain. And with lecanemab, the studies also showed less decline in the quality of life as assessed by patients and less rise in burden by the care partners. And we know as disease progresses, a disease like Alzheimer's, quality of life diminishes and care partner burden increases. And what we're seeing with lecanemab is less of those things happening. So what's next for these anti-amyloid drugs? For lecanemab and donanemab, Health Canada is currently reviewing both of these. We expect by the end of the year to hear their determination, whether they agree to approve these drugs. Meanwhile, prevention studies are going on with both of these drugs. I think in Toronto at our clinic, we have the largest cohort of patients in the lecanemab prevention study. There's also a subcutaneous formulation of lecanemab under development. It's actually under review by the FDA right now. So this means that in the future, rather than having to go to a center or hospital and have intravenous treatment, people would be able to give themselves a shot at home, just the way people administer insulin on their own. There are other anti-amyloid antibody programs going on, as well as other approaches to amyloid, including genetic approaches to prevent people from developing amyloid in the first place. And you will hear more about these in the future. They're very, very exciting. Apart from amyloid, there are other disease-modifying treatments that are actively enrolling participants and are the hope for the future, along with the anti-amyloid programs. So these are anti-tau studies with antibodies to clear tau and reduce the spread of tau from cell to cell, and also drugs to reduce the formation of tau, so similar to the approach to amyloid. And then we have learned in recent years that the immune system is not working properly in Alzheimer's disease, and drugs to reduce inflammation in the brain are under development, and drugs to activate immune cells to make them work better to clear amyloid and other toxins are also under development. If we can boost the protective functions of the support cells, which are often the immune cells in the brain, then the brain can weather disease better. And what about lifestyle strategies? So we hear a lot about, learn a new language or do more crossword Sudoku. Is there something to this? Well, the Lancet Commission says actually up to 50% of dementias may be preventable through lifestyle modification. So when they're talking about dementia here, they're talking about all causes of dementia. So if you wear a helmet, when you're playing hockey or riding a bike and you avoid that head injury, yes, that's a prevention strategy. That's important. That's not the same as focusing in just on preventing Alzheimer's disease. Nonetheless, some of the brain healthy lifestyle strategies are important in Alzheimer's disease, and I've listed some of them here. So staying mentally engaged, and that means pursuing activities that are enjoyable and challenging, and that entail some problem solving, whether it's a game of chess or whether it's us sitting here today learning together, and we'll have a Q&A session that'll be even more interactive and we'll get a chance to discuss things. This is the kind of mental activity the brain likes. If you're someone who likes Sudoku or crosswords, more power to you. That's great. If you want to learn a new musical instrument, that's great. But please know that you should follow your interests and do the things that you enjoy. And that really opens up the menu very broadly. There are no mental activities that are bad. They're all good for the brain. And if they have some problem solving involved, that's good too. Travel is one of those activities. Physical exercise is very important for the brain. We know it's important for controlling hypertension and diabetes, but we've understood in recent years that with physical exercise, we actually have an increase in chemicals in the brain that protect brain cells. So exercise approximately 3 times a week, 150 minutes per week, and it can be a whole range of exercise. It can be walking. It can be, you don't have to run a marathon. This is not exercise designed for the elite athlete. It's whatever you like to do, whether it's golfing, dancing, gardening, but brisk walking is very good exercise, good for brain health. In terms of dietary pattern, a diet that is low in animal fat, low in red meat is felt to be the best. And that doesn't mean you can't have a hamburger. And, in Canada, we like our summer steaks and burgers, but you don't want that to be on the menu every day. So more fish, poultry, and lots of fruit, vegetables, nuts, salads. Sleep is important. Sleep eludes many of us, but the quantity and quality of sleep are important for brain health. And controlling stress is important, making time for things you find enjoyable and relaxing. Stress is ubiquitous. It's hard to eliminate all stress, but you want to try and manage it. Make some time for yourself. And then controlling what we call vascular risk factors. So smoking, high cholesterol, high blood pressure, diabetes. These things, if not controlled, contribute to the risk for Alzheimer's disease. So there are many, many reasons to join a clinical trial, and I will just highlight these. It is hard to get specialized healthcare when it comes to memory problems. When you join a trial, you get access to specialized diagnostic tests not otherwise available or not otherwise cost covered. You get access to cutting edge treatments under development and not yet available by prescription. So you may get a jump on, what will come to the market by 3 to 5 years, which is important in a progressive disease. You get access to an expert team of specialists who are interested in you and knowledgeable, close monitoring of one's condition, and the satisfaction of knowing that you're doing everything you can for yourself and for your family and for future generations. I like to show this slide because it indicates what our pharmacies would be like if we had no clinical trials. There would be no drugs for COVID, no drugs for diabetes, no drugs for asthma. When you next pick up your prescription in the pharmacy, just give a moment's thought to the fact that many, many volunteers around the world and research sites participated in the development of that drug and allowed it to cross the finish line so that you have it to treat your asthma or whatever it is you're picking up the drug for. It's really something that I think people don't realize, the effort behind drug development. So don't doubt progress. Please help accelerate it if you're so interested. People who know this disease want to be involved. That's been our experience. And there are many things you can do. And Justine will come on in a moment to give you an idea of how we could organize a baseline memory test if you like. We're in the habit of offering free memory testing because people find it very hard to get this otherwise. You can join our prevention or treatment registry. You can undergo a cheek swab to check for the Alzheimer's risk gene if you like, and you can find out if a clinical trial is right for you or someone you care about. Again, it's not all about drugs and it's not all about research. Caring for people who are affected, particularly in later stages of disease, is extremely important. And I applaud the efforts that are going on there, including advocacy and efforts to make dementia-friendly communities with less stigma and more social interaction. There are communities and new, frameworks for community living where people who are at later stages and need supportive housing don't have to live in the traditional, rather isolating nursing homes. So we hope to see more dementia-friendly communities in Canada. We all have a role to play to end Alzheimer's. That's my mission. I want to end this disease, bad disease. So I'm very happy to answer your questions, but maybe first I'll turn to Justine. Well, here's a little, some of us say, okay, well, if it's my destiny to develop Alzheimer's disease, so be it. But I don't want my children or my grandchildren to have to deal with this. So let's protect the next generations. And now I will turn to Justine. Just you could give a few words how people might get involved if they're interested. Thank you. I'll stop sharing my screen.
Of course. Hi, everyone. My name is Justine. I'm the manager of, oh, thank you. Can you hear me?
Yep.
Sharon, can you hear me? Oh, okay, great.
Yes, I can.
My name is Justine. I'm the manager of clinical trial recruitment at Toronto Memory Program. It's nice to meet you. We do offer free memory testing. So anyone that's interested in memory testing, it's about a 30-minute appointment. We can do it at our memory clinic, which is in North York, and we can do it virtually over Zoom, depending on your preference. The cheek swab and the genetic testing we do at our clinic. And anyone who's interested in research, I'm happy to hop on a call and answer any questions that you have about that. But we will send a follow-up email to all of the attendees today with our contact information. So if you are interested in any of these services or have additional questions after the talk today, please feel free to reach out. So we'll move on to, of course, we'll move on to the Q&A. You can definitely verbally ask your question if you'd like to Dr. Cohen, or if you'd like, you can write them in the chat and I can read them aloud for you. So if you raise, oh, we got one hand raised. Bruno, go ahead.
Dr. Cohen, thank you very much for that fantastic presentation.
You're so welcome.
I learned a lot. Can you help me understand the distinction between drugs that address the symptoms and drugs that are potentially curing? Like you
Sure.
said, this one here, the orange one addresses the symptoms. What does that mean?
Right. So I think the orange one, that's donepezil. So the brand name was originally Aricept. That was the first drug ever marketed for Alzheimer's disease, 1997 in Canada. It is the most prescribed around the world. And what it does is it boosts a chemical called acetylcholine, an important chemical in the brain, which is what we call a neurotransmitter. Neurotransmitters are chemicals that brain cells use to communicate with each other. And in a disease like Alzheimer's disease, and also in some other diseases that affect memory, there's not enough acetylcholine being made. So we give this drug, donepezil, and it boosts the amount of acetylcholine, and that helps support memory and thinking.
Oh, she froze.
Sorry, Dr. Cohen, I think we just lost you for a second.
On their end.
Oh, looks like she is off, so she might be, oh no, she's still here.
Yeah, she froze.
That's bizarre.
Yeah, we just see it freezing.
So Justine, as we wait, how do we get involved in this? Like, where are you at Baycrest? Where are you located?
We're actually near Baycrest, so we're in North York. We're near Don Mills and York Mills. Typically, if someone's interested in research, we'll start by doing a health questionnaire together. We'll do some memory testing. Even if you've had testing recently, we like to repeat it. And that testing will help give us an idea of what our research opportunities are. We have a whole host of research opportunities, from Alzheimer's disease prevention to mild cognitive impairment to mild dementia for Alzheimer's due to Alzheimer's disease. So we'd want to narrow down our options, and that way we can talk about a specific study. Oh, so there's a power outage at the office.
No.
So I might be able to answer some questions if I'm just going to let Dr. Cohen know, no problem. Okay. I'm so sorry. So I guess there was a power outage.
She can join via her phone, by the way.
I have a feeling that she would not be able to join from her phone. We might, I don't know what your preference would be, but we could set up a Q&A virtual talk for this week or the following week, if that's possible. Because I'm sure that there's a lot of questions. I can see that there's hands raised. There's a couple questions in the chat. Whatever your preference is.
Why don't we see if there's any questions for you, Justine?
Sure. Yeah, absolutely. So we have a couple people with hands raised. I think the most recent, Kush.
Yes. Hi. Thank you for taking my call. Excellent presentation by Dr. Cohen, and you can pass that message on to her.
Will do.
My question is that what is the difference between, say, normal memory loss due to aging and the serious dementia or Alzheimer's? For example, I gather everyone goes through a phase when they're, say, over 65, 70, where you forget your keys or where you put this or that, and then you start worrying, do I have dementia? Do I have Alzheimer's? And where's the point where you start to get really worried and go in for testing that you've suggested?
Sure. So we recommend, just like, you have regular checks on your heart and everything, to have a regular check on your memory. Even if you're not noticing changes in your memory, it's good to get a baseline memory test done.
Right.
That way, if you notice changes in the future, we can compare back to that original test and see if there's any changes. Memory loss isn't normal as you get older. So, we would definitely want to do a memory test just to confirm that, there's nothing else going on.
One quick request. Can you kindly forward this presentation to everyone who's attended today?
Yes, absolutely. And I think it was recorded as well.
Oh, thank you very much.
Yes, Colin here, just confirming we set up to record the message. If you can send that to myself, Justine, Nazma and I will be happy to relay it on to our members.
Great, will do. There are a couple questions in the chat. I can quickly see if I'm able to answer any of those. So genetic testing, yes, we do the genetic testing at no cost at our site. We have someone asking about scheduling an appointment for that. It is testing for that risk factor gene for Alzheimer's disease. It's called APOE. The appointment, if you're just interested in the genetic testing, is only about 10 minutes. You come in, we go through a consent form. We'll take your cheek swab, and it's processed in that little DNA analyzer in about an hour and 6 minutes. So by the end of that day, when you come in, you'll get your result, and you'll also get a webinar that talks about what your result means. So we'd be happy to schedule that appointment in. Someone's asking about our website. I will definitely send a follow-up email. It'll include our website. It'll include our contact information. And if you're interested in any of our services, we can definitely pursue that. All of our services are covered by OHIP in our memory clinic. So there's no costs associated with seeing a physician in our clinic. And if you're interested in research trials, there's no costs associated with participating in a study either. Everything is covered by the sponsor, the pharmaceutical company that's running the study. So they actually reimburse for your time a little bit as well. Sometimes it can be $50 to $80 for visits. If you're coming from far, sometimes they will cover your ride program, they'll cover hotel, anything to make it easy for you to get in. Nazma, I saw you have your hand up. I'm not sure if I can answer your question, but I can certainly try.
Okay. I went through your memory clinic, and I found out I don't have Alzheimer's, but I do have the genes, the 4 genes there, that one of my parents has Alzheimer's. How often should I wait to go and get tested again to see the progress?
I would say it's a good rule of thumb to have a memory test once a year.
Okay.
So if you came in this year, reach out, set a reminder next year to reach out, and we can do a repeat memory test. Did you participate in a research study or memory testing?
The research study.
Oh, okay, fantastic. So
Yeah.
okay, perfect.
And,
Yeah, we
and
can.
I came in for the test, for my blood test. And the
Oh,
swab.
okay, you had the blood test. Okay,
Yeah,
great. So
and
when a
that's
blood
when they
test
found
is
out-
negative. Oh, okay,
yeah,
that's
yeah,
that's
that's
good
when I
news.
found out I have the genes. I don't have the Alzheimer's, but I do have the genes. But it didn't tell me how often I have to come in to see the progress as I go on.
Okay, so if you notice any changes in your memory and you feel like your memory is getting worse, definitely reach out to us and we can organize another memory test. I would say give it a year. We can do a repeat memory test. Typically, we'll wait about 2 years after the negative blood test, which is
Okay.
good news.
Great. And also there was a thing that she was going to talk about and she didn't have a chance is there's villages, the village like in Langley for dementia patients. I know it's expensive, but maybe you want to talk about it. Is it any possibility of having it in Ontario and what it's about, please?
So I don't have any information on the villages, but I can get that information and send that to you after the presentation, if that's okay.
Thanks.
No worries.
Cohen,
Other
did you
Hi,
finish your
everyone.
question?
I'm so sorry that we lost power in the office. Who knew? And thank you for jumping in. And Bruno, I'm sorry. I hope you got your question answered. Justine, were you able to
So
continue on with Bruno?
just in a nutshell, what's the difference between treating the symptoms and treating the cause?
Yeah. So treating the underlying cause of a disease, whether it's Alzheimer's or cancer, is the way to keep the disease at bay, either prevent people from getting worse, or, in cancer, we have treatments for underlying cause that can actually reverse and cure the disease. We're not there yet with Alzheimer's, but we have treatments that can slow down the disease so people stay in the mild stage longer. When you treat symptoms, that's a little bit different. You get a boost in symptoms, let's say memory is the symptom. That's good. You want improvement, but the underlying disease continues. So if I could give you an example from cancer medicine, if somebody has a brain tumor and they've got headache because of the tumor, treating the headache is the right thing to do, whether it takes Tylenol or something stronger. You don't want people in pain. However, that symptom treatment, the Tylenol, is not going to get rid of the tumor. You need either chemotherapy, radiation, or something else to get at the biology of the condition. So that kind of analogy sometimes helps people understand the difference between treating symptoms and treating the disease more definitively. I hope that helps, Bruno. Thank you for your question. It's a good one.
Thank you.
You're welcome.
Thank you. I took some of the easier questions while you were gone, but
I'm sure you did
some of
fine.
thank you. Some of the other questions are about vitamins. Are there any vitamins that enhance memory?
Oh, thank you. Okay. Yes, this is a really interesting area of study. So anybody who is deficient in vitamins, and particularly when we're talking memory, it's vitamin B12, probably any of the B vitamins, but B12 is the most important. It is really important to get your B12 level up to normal or even above normal levels. There's no toxicity associated with vitamin B12. It is absolutely essential for the brain as well as for the hematologic system. People can get anemia and other serious problems when B12 is low. But usually it just takes oral tablets you can get over the counter in the pharmacy, and you need to get your B12 rechecked to make sure that it's coming up sufficiently. Sometimes people don't absorb the B12 well enough, and then you need a shot of B12 once a month. For the other vitamins, all the vitamins are important for general health. Whether they play an important role in brain health is debated, but there aren't any lines of evidence that suggest giving yourself mega doses of vitamins, whether it's vitamin C or D, if you don't have a deficiency, that helps. So I would say spend your money on something that you enjoy more than taking vitamin supplements if you're not deficient in a vitamin.
Thank you very much. How do you differentiate between memory loss due to age and Alzheimer's?
Yeah, it's a great question. And I think that anybody who feels their memory is not as good as what it used to be should get it checked out. Sorry. It is very difficult to judge one's own memory. And people go between two extremes. Oh, all my friends say they're forgetful. This is normal. I'm not worried. To the other extreme where I'm very worried about Alzheimer's. That's what my aunt developed. Get it checked out, and you need to go to a specialty memory clinic. where more detailed tests can be done to sort out the difference between normal aging and more serious memory impairment.
Thank you. I think that's all the questions so far. No one else has their hand raised. We covered everything in the chat. Maybe give it a second just in case.
Terrific.
Sorry, I don't know how to put the hand up, but could I ask a question?
Of course.
Is it better to go to the family doctor, like you're saying, they're not really up on all the testing, or is it better to go directly to your memory clinic?
Yeah, that's a great question, Carol. So as you know, in Canada and in Ontario, the family doctor is the gateway to the specialist, and most specialists require a referral. What I would say is these are the two options. You can go to your family doctor and say, you know, I'd like to have a memory test. Will you please refer me to a specialist? And to ask for that referral so that you don't get into the situation where the family doctor says, oh, no, don't worry about it. I don't think there's anything going on. If you're concerned about your memory or you want a baseline memory test, the specialty memory clinics are happy to do that. So we can, you know, I would suggest that you let them know you want a referral to a specialist. Would they please do that? The other option is that you can call us. We have a research line that doesn't require people to have a referral from their family doctor as the point of entry. And we will arrange for you to be seen in our clinic, if that makes sense. So even if research doesn't end up being, you know, the path that you want to follow or the most appropriate way, it gives you a foothold, because we will reach out to your family doctor and say, you know, your patient approached us, is interested in memory screening. Would you kindly send us a referral? I've never seen a family doctor say no. They're grateful to have the support for their patients. They sometimes just don't know where to send their patients. So there are ways around this, and Justine can provide you with our access number. Hope that helps. We see
that's
many
good.
people who have, you know, kind of been put off for years, and then they come to us and there is something going on, and they knew it for a long time and they didn't have the benefit of seeing someone early enough. So yeah, we hate that to happen.
Yeah. Okay, thank you.
You're welcome.
Oh,
Bruno, did you have another?
Sorry, go ahead. Let somebody else go ahead.
So if somebody else has a question, go ahead.
Bruno, that's okay. You go ahead.
I've got lots of questions because I've been leading support groups in Parkinson's for the last 12 years. So thank you very much for your research. There's a great need in Canada for this. Canada has the highest rate of MS and Parkinson in the world. Is that true for Alzheimer's as well? And are they all related to something that's happening here in our environment?
Wow, I love your question. So yes, we do have a high rate of MS, definitely. Our rate of Alzheimer's disease is fairly consistent with the rates around the world. This is a very common disease. It's about 10 times more common than Parkinson's disease, and Parkinson's disease is not rare. MS is less common than both of these diseases. Although not rare, we wouldn't call it a rare disease. So Alzheimer's is the commonest of these degenerative diseases of the brain, and the rates are very consistent around the world. Canada's not, you know, sort of a higher rate or a lower rate. And I think that, you know, governments, healthcare systems are taking note now, because Alzheimer's is becoming the most expensive disease. It's interesting in terms of, you know, how are these diseases connected? Well, with Parkinson's and Alzheimer's, there is a similar biology. And by that, I mean, there is an abnormal protein that gets the disease started in the brain. For Alzheimer's, we've talked about amyloid. With Parkinson's disease, it's a different protein. It's got a funny name, alpha-synuclein. So it's alpha-synuclein, but it does the same thing. It increases in the brain, damages brain cells more in the motor areas, but can also affect thinking and memory. So, you know, about 50% of people with Parkinson's disease in later stages of Parkinson's will develop some problems with memory and thinking. So we can add that to the list of causes of dementia, Parkinson's disease, dementia. And interestingly, donepezil seems to help that condition as well in terms of the memory and thinking. So some of the drugs being developed for Alzheimer's may also help for Parkinson's disease. That's
Thank
a whole
you.
lot. I hope it wasn't too confusing.
We have one additional question. Do you suggest doing the Cognicity online memory test through Baycrest?
Oh, that's interesting. Yeah. So there is an online test. It's called Cognicity. You do it yourself, in the privacy of your home. It's a computerized test. And yeah, I believe you receive a score. I guess there's nothing wrong with that test, but it is certainly not one of the more common, well-validated tests. It's very specific to the normative ranges and things they've worked out at Baycrest. And I think that, in terms of entry to clinical trials or knowing how to monitor or taking that score to your family doctor and saying, here's my memory test, and somebody being able to interpret that, it doesn't translate that well. So my preference is always that you link with a memory specialist rather than just do the online test.
Great. And that
So
ends.
somebody can interpret the results for you and make sense of it. Yeah, sorry.
Oh, that's okay. No, that makes sense. And that ends the questions for today.
Wonderful. Thank you all for your great questions. I do apologize that I skipped out for a few minutes in the dark here, but you guys are great. Thank you.
Colin here. I just wanted to say thanks everyone for participating, and thank you, Dr. Cohen and Justine, for conducting a wonderful, informative presentation. We expect to give us about 72 hours, and we'll notify everyone when our post-meeting material is available and how to get to it. Thank you again for participating and for conducting this wonderful event.
You're so welcome. Really appreciate it. And I saw there was another question that came through, but if there are additional questions, we're happy to take them offline and respond to them. So yes, please feel free to reach out to us. Thanks so much. Have a great day, everyone.
Thanks, everyone.
Everybody, thanks.
That's it. Okay, done.